Now we will see the management of myocardial infarction. The ECG usually identifies the location and the patient history identifies the timing. Regardless of the location of the infarction of cardiac muscle, medical management is to minimize myocardial damage, preserve myocardial function, prevent or minimize myocardial tissue death, and the prevention of severe outcomes such as death or myocardial infarction or reinfarction. These goals are achieved by reperfusing the area with the emergency use of thrombolytic medications or PTCA, that is percutaneous transluminal coronary angioplasty. Minimizing myocardial damage is also accompanied by reducing myocardial oxygen demand and increasing oxygen supply with oxygen administration, bed rest, and administration of anti-ischemic therapy, antithrombotic therapy, and ongoing risk stratification and use of invasive procedures such as cardiac catheterization to provide early restoration of coronary blood flow. Most MIs occur in the person with the pre-existing coronary artery disease. The expression "time is muscle" reflects the urgency of appropriate treatment to improve patient outcomes. The resolution of pain and ECG changes are the primary clinical indicators that demand and the supply are equilibrium. They may also indicate reperfusion. Visualization of blood flow through an open vessel in the catheterization laboratory is evidence of reperfusion. It is very important to quickly diagnose and treat a patient with acute coronary syndrome to preserve heart muscle. Initial management of the patient with chest pain most often occurs in emergency department. What are the initial management? If the patient is unresponsive, assess circulation, airway, and breathing. If the person is responsive, monitor airway, breathing, and circulation first. If it is not contraindicated, position the patient upright. Give oxygen by nasal cannula or non-rebreather mask to keep oxygen saturation above 93%. Obtain baseline vital signs including oxygen saturation, auscultate heart and breath sounds. Obtain 12-lead ECG. If the ECG shows ST elevation, the patient is taken directly for cardiac catheterization. Obtain IV access for drug administration. Insert 2 IV catheters. Assess pain. Administer pain medications if ordered. Give sublingual nitroglycerin and 162 to 325 mg of a chewable aspirin if not given before arrival at the emergency department. Give aspirin for heart-related chest pain unless contraindicated. If the pain is not relieved by nitroglycerin, give morphine. Start continuous ECG monitoring and identify underlying rhythm. Obtain baseline blood work, for example, cardiac biomarkers, CBC, basic metabolic panel coagulation studies. Obtain portable chest X-rays. Assess for contraindications for antiplatelet, anticoagulant, or thrombolytic therapy or percutaneous coronary intervention as appropriate. Thrombolytic therapy is started if the patient is unable to be quickly transported to a PCI-capable hospital. If the ECG shows ST depression and or T-wave invasion, we admit the patient to an ICU or telemetry unit for ongoing care. PCI or percutaneous coronary intervention is a non-surgical invasive procedure with the goal of relieving the narrowing or occlusion of the coronary artery and improve blood supply to the ischemic tissue. Percutaneous coronary intervention is a treatment to open a blocked artery. Client may need a PCI if have a buildup of a fatty, waxy substance in the arteries or may have a PCI to clear blockages after a heart attack. Another name for a PCI is coronary angioplasty. Give a high dose statin. Give anti-dysarrhythmic drugs for life-threatening dysarrhythmias. Cardiac biomarkers are drawn until the peak level drops off. Unstable angina and non-STEMI patients start on heparin or GP2B or 3A inhibitors, either before catheterization or at the time of PCI. We will be covering the drugs in details. Now we will see the ongoing monitoring. What we have to monitor continuously. Monitor ABCs, vital signs, level of consciousness, heart and breath sounds, heart rhythm and oxygen saturation. Assess and record response to drug if the patient is having a decrease in chest pain, and remedicate or titrate drugs if needed. We have to provide reassurance and emotional support to patient and caregiver. Explain all interventions and procedures to patient and caregiver in simple terms. Anticipate need for intubation if respiratory distress is evident. Prepare for CPR and defibrillation if cardiac arrest is evident. Anticipate need for transcutaneous pacing for symptomatic bradycardia or heart block. Now we will cover drug therapy. Thrombolytics are medications that are usually administered intravenously, although Some may also be given directly into the coronary artery in the cardiac catheterization laboratory. The purpose of thrombolytics is to dissolve and lyse the thrombus in the coronary artery, that is called thrombolysis, allowing blood to flow through the coronary artery again, that is reperfusion, minimizing the size of the infarction and preserving ventricular function. Even though thrombolytics may dissolve the thrombus, they do not affect the underlying atherosclerotic lesion. Examples of thrombolytic agents are retroplase, autoplase, tenectoplase. Thrombolytic therapy is indicated only for patients with STEMI that do not have an interventional cardiac catheterization laboratory or when one is too far away to transfer the patient quickly. Treatment of STEMI with thrombolytic therapy aims to limit the infarction size by dissolving the thrombus in the coronary artery to reperfuse the heart muscle. The goal is to give the thrombolytic within 30 minutes of the patient's arrival to the emergency department. All thrombolytics are given IV. Thrombolytics dissolve all clots, not just the one in the coronary artery. Because thrombolytics lyse the pathologic clot, they may also lyse other clots. Therefore, they should not be used if the patient has formed a protective clot, such as after major surgery or hemorrhagic shock. Because thrombolytics reduce the patient's ability to form a stabilizing clot, the patient is at risk for bleeding. Patient selection is important because minor or major bleeding can be a complication of therapy. Inclusion criteria for thrombolytic therapy are chest pain less than 12 hours with 12 lead ECG findings consistent with STEMI and with no absolute contraindications. Patients with chest pain lasting 12 to 24 hours with ECG changes supporting STEMI may be considered for thrombolytic therapy. We will see the procedure, how we can give thrombolytic therapy. Each hospital has a protocol for giving thrombolytic therapy. We complete 2 common steps before starting thrombolytic therapy. First, we have to draw blood to obtain baseline laboratory values and start 2 or 3 lines for IV therapy. Perform all other invasive procedures before giving the thrombolytic agent to reduce the risk of bleeding. Depending on the drug selected, therapy is given either by an IV bolus or via an infusion over up to 3 hours. Note the time when therapy begins. Monitor the patient during and after the thrombolytic therapy. Assess heart rhythm, vital signs and pulse oximetry. Assess the heart and lungs often to evaluate the patient's response to therapy. Regularly assess for changes in neurological status that may indicate cerebral bleeding. When reperfusion occurs, several clinical signs can be seen. That is when a blocked coronary artery is open and blood flow is restored to the heart muscle. The most reliable sign is the return of the ST segment to baseline on the ECG. Other signs include resolution of the chest pain and an early rapid rise of serum cardiac biomarkers. These levels increase as the necrotic heart cells release proteins into the circulation after perfusion is restored to the area. The presence of reperfusion dysarrhythmias, that is accelerated idioventricular rhythm, is a less reliable sign of reperfusion. These dysarrhythmias are generally self-limiting and do not require aggressive treatment. A major concern with the thrombolytic therapy is reocclusion of the artery. The site of the thrombus is unstable and another clot may form. Therefore, IV heparin therapy is started. Another clot forms. The patient will describe similar chest pain symptoms and ECG changes will return. Patients receiving thrombolytic therapy should be moved to an agency with PCA capabilities as soon as possible, so PCA can be done if thrombolytic therapy fails. The main complication with thrombolytic therapy is bleeding. Ongoing nursing assessment is necessary. Minor bleeding is expected. Control bleeding by applying manual pressure followed by a pressure dressing or ice pack. What are the contraindications for thrombolytic therapy? Thrombolytics should not be used if the patient is bleeding or has a bleeding disorder. All patients who receive thrombolytic therapy are placed on bleeding precautions to minimize the risk for bleeding. This means minimizing the number of punctures for inserting intravenous lines, avoiding intramuscular injections, preventing tissue trauma, and applying pressure for longer than usual after any puncture. Absolute contraindications are active internal bleeding, history of intracranial hemorrhage, intracranial or intraspinal surgery within 2 months, non-structural or vascular abnormality, that is arteriovenous malformation, non-intracranial cancer, that is primary or metastatic, recent ischemic stroke, that is within 3 months, severe uncontrolled hypertension, significant closed head or facial trauma within past 3 months, suspected aortic dissection. For streptokinase, prior treatment within the past 6 months. Streptokinase is a thrombolytic agent, usually cannot be administered safely a second time within 6 months. Relative contraindications are active peptic ulcer disease, current use of oral anticoagulants, dementia, history of chronic severe poorly controlled hypertension, non-intracranial pathology not covered in absolute contraindications, major surgery less than 3 weeks, non-compressible vascular punches, pregnancy, prior ischemic stroke more than 3 months ago, recent internal bleeding within 2 to 4 weeks, significant hypertension on presentation, traumatic or prolonged cardiopulmonary resuscitation, given for more than 10 minutes. Next drug therapy is nitrate. Nitrates are given sublingually via spray or through IV administration. Vasodilator therapy reduces preload by decreasing blood return to the heart and decreasing oxygen demand. It promotes peripheral vasodilation, decreasing preload and afterload. It promotes coronary artery vasodilation. It may prevent or control coronary vasospasm. IV nitroglycerin is used in the initial treatment of the patient with acute coronary syndrome. Sublingual NTG can be used until the IV NTG is prepared. The goal of therapy is to reduce angina pain and improve coronary blood flow. IV NTG decreases preload and afterload while increasing the myocardial oxygen supply. The onset of action is immediate. Titrate NTG to eliminate chest pain. Because hypotension is a common side effect, closely monitor BP. Patients who become hypertensive may be oleum depleted and may benefit from an IV fluid bonus. Closely assess for fluid overload after the bolus. If the patient is having fluid overload, crackles on lung auscultation may be present. The examples of nitroglycerins are isosorbide dinitrate, isosorbide mononitrate, sublingual nitroglycerin, translingual spray nitroglycerin, nitroglycerin ointment, transdermal nitroglycerin, IV nitroglycerin. Next drug is opioid. The example of opioid is morphine. Morphine is the drug of choice for chest pain that is unrelieved by NTG. As a vasodilator, it decreases cardiac workload by lowering myocardial oxygen consumption, reducing contractility, and decreasing BP and heart rate. Morphine can help reduce anxiety and fear. In rare situations, morphine can depress respirations, monitor BP, level of consciousness, and respiratory rate. Monitor patients for signs of bradypnea or hypotension, which are conditions to avoid in myocardial ischemia and infarction. Next drug is sodium current inhibitor. Example is ranolazine. This drug uses to treat chronic angina in patients who have not had an adequate response with other anti-anginal medications. Ranolazine is an inhibitor of the lead sodium current, reduces the frequency and severity of anginal attacks and ST segment depression. Unlike other anti-anginal drugs, ranolazine does not alter heart rate or blood pressure. Next drug is beta-adrenergic blockage. Beta-adrenergic blockage inhibits sympathetic nervous system stimulation of the heart, thus decreases myocardial oxygen demand by reducing heart rate, BP, and contractility, and reduce ventricular remodeling and decrease endothelial dysfunction. They are given to patients who are not at risk for complications of MI, such as cardiogenic shock, bradycardia, hypotension. They reduce the risk for reinfarction and heart failure. Cardioselective beta blockers include atenolol, bisoprolol, and metoprolol. Next drug of choice is angiotensin converting enzyme inhibitors. It prevents conversion of angiotensin 1 to angiotensin 2, resulting in vasodilation. It may prevent or limit ventricular remodeling. It decreases endothelial dysfunction. ACE inhibitors should be started within the first 24 hours if the BP is stable and there are no contraindications. They are taken indefinitely in patients after STEMI or non-STEMI with heart failure or an ejection fraction of 40% or less. ACE inhibitors can help prevent ventricular remodeling and prevent or slow the progression of heart failure. Start with the drug with a short half-life such as captopril within 24 hours to treat acute MI. On discharge, switch to to a longer-acting drug such as lisinopril or enalapril. Next drug is angiotensin II receptor blockers. Angiotensin II receptor blockers decrease the effects of angiotensin. This protein causes blood vessels to become too narrow, leading to high blood pressure. As also treat heart failure and kidney disease and lower the risk of heart attacks and strokes. The medicines relaxes blood vessels so blood flows more freely. The examples are losartan, valsartan. Next drug is calcium channel blockers. Calcium channel blockers prevents calcium entry into vascular smooth muscle cells and myocytes. It may prevent or control coronary vasospasm. It promotes coronary and peripheral vasodilation. It reduces heart rate, contractility, and BP. Examples are nifedipine, amlodipine, diltiazem, and verapamil. Next drug of choice is anti-dysarrhythmic drugs. These arrhythmias are the most common complications after an MI. In general, they are self-limiting and not treated aggressively unless they are life-threatening. Anti-arrhythmics such as amiodarone and correction of electrolyte imbalances decreases ventricular irritability that occurs after MI. Bolus of amiodarone is given via IV line over 10 minutes, then an infusion is given in varying doses over 24 hours. 1 mg per minute for 6 hours, then 0.5 mg per minute for 18 hours. Examples of anti-dysarrhythmics are amiodarone, procainamide, quinidine, lidocaine, frecanide. Now we will see the anticoagulant agents. There are different types of anticoagulant agents. Direct thrombin inhibitors. It inhibits the clotting factor thrombin directly. Examples are bivalirudin, argatroban. Next type is low molecular weight heparin. It has shorter molecules, which means it can only attach to antithrombin drugs. So it binds to antithrombin drug, enhancing its effect. Next drug is unfractionated heparin. Unfractionated heparin is stronger and fast acting, which means it is long enough to help wrap around both antithrombin and thrombin, a protein that promotes clotting, holding them together. This neutralizes both proteins, further preventing clotting. Next is vitamin K antagonist. Example is warfarin. It interferes with the hepatic synthesis of vitamin K dependent clotting factors. Next drug is factor XA inhibitors. Examples are apixaban, rivorixaban. It blocks the clotting activity of factor XA to prevent clot formation. Next is antiplatelet agents. Example is aspirin. Aspirin is given as soon as ACS is suspected, unless truly allergic. Aspirin helps to stop platelet aggregation. If patient is allergic to aspirin, give clopidogrel or ticlopidine. Clopidogrel is used in combination with the low-dose aspirin to treat ACS with or without PCI and after elective PCI for CAD, coronary artery disease. Cangrelor, prasugrel, or Rapexar are different antiplatelet drugs. These drugs inhibit platelet aggregation. Next drug of choice is glycoprotein 2B or 3A inhibitors. It prevents the binding of fibrinogen to platelets, thereby blocking platelet aggregation. It may be used in combination with aspirin for patients with ACS or during PCI. The examples are tirofiban, eptifibatide, abscimab. All patients with ACS need a lipid panel. Patients with ACS or CAD should receive lipid-lowering drugs indefinitely. Examples are simvastatin, lovastatin. Next drug of choice is aldosterone antagonist. Aldosterone antagonist can decrease mortality after a STEMI regardless of the LV function. Examples are spironolactone, eplerenone. One of these drugs should be added if there are no contraindications, such as hyperkalemia or increased creatinine level. After an MI, the patient may be predisposed to constipation because of bed rest and opioid drugs. Stool softness prevents straining and the resultant vagal stimulation from the valsalva maneuver. Vagal stimulation produces bradycardia and can provoke dysarrhythmias. A laxative may be used if needed. Example is docusate sodium. Initially, the patient may be NPO, that is nothing by mouth, except for water until the patient is become stable. Advise a diet as tolerated to a low salt, low saturated fat and low cholesterol diet. The patient with a STEMI must undergo cardiac catheterization within 90 minutes of presentation to the emergency department or receive thrombolytic therapy within 30 minutes in agencies without PTCA capability. The goal is to open the totally occluded artery and limit the infarction size. The patient with unstable angina or non-STEMI usually undergoes cardiac catheterization during the hospitalization to diagnose and evaluate the extent of the disease. They do not need an emergent catheterization. It can be done within 12 to 72 hours after presentation. Complications of myocardial infarctions are dysarrhythmias, heart failure, cardiogenic shock, papillary muscle dysfunction or rupture, left ventricular aneurysm, ventricular septal wall rupture, and left ventricular free wall rupture. Pericarditis, Dressler's syndrome. Dressler's syndrome is pericarditis and a fever that develops 1 to 8 weeks after MI. Although the cause is unclear, it may be an autoimmune reaction to the necrotic heart muscle.